Bob Kruger to speak to us today on depression in the elderly. I guess congratulations are in order because I understand he's recently retired from the Air Force after many years.
I have 23 years, 29 if you count medical school.
Oh, okay.
So, which they do.
That's terrific. Well, most recently he was at Wilford Hall where he was directing geriatrics programs there, consultation and teaching was first ever there. And since his retirement, I guess he's been in the hospitalist.
I have. I'm a sniffist. I work with hospitalists of San Antonio, now IHS hospitalists, so I'm their sniffist. Work and see patients. I have a panel of 50 patients in 6 different facilities, which is an interesting logistical challenge.
Yeah, a lot of travel. Anyway, it's a pleasure to welcome you, and I hear that you miss your teaching responsibility, so allow us to satisfy that.
Thank you very much. Oh, okay, great. Well, while you're doing that, let's. I have kind of like when you go to the movies. The first, if you arrive on time, you're going to see 10 minutes of previews. If you arrive late, you're going to see your movie. So I'm going to give you a preview. But it's a preview you all are going to like because this is. There's a. One of my favorite articles came out about 18 months ago in the Archives of Internal Medicine, and it's called Physician Career Satisfaction Across Specialties. And look at this. This is a great article. They took 12,474 physicians. The response rate 65%. That means the ones who really were excited responded, or the ones who were really disgruntled responded. And they said, how do you like your job? And so people said, I either love my job or I hate my job. But this is something I really want you to see. Take a look at this. This is logistic regression recalls for very satisfied, ranked from high to low odds ratios. And they rank family practice right in the center, and they said all the world is family practice, and we're all just sort of doing other things. They do everything, so we'll say that they like their career. So based on family practice, who likes their career? Geriatric internal medicine in this came up on the top. I'm very satisfied with my job, and that's what I see a lot in geriatricians. They like their job. They like the stuff you do. So if you're a geriatrician, you can pat yourself on the back that you made a good career move. And if you're not a geriatrician,
but are we assessing when every year when these lists come out of the most satisfying careers, they'll always, the number one is actuary. So I wonder if first happy is actuary.
Yeah, that's right. Then they said, how about dissatisfied? Tell us who's dissatisfied. I guess very satisfied is not the same thing as very dissatisfied. It's not a 100% reverse. But again, we hit it. We are at the bottom of the list here on dissatisfied. And all those years that they went, you know, and they're very dissatisfied. I don't like my job. OBGYN, same thing. Ophthalmology, that was the treasure, but they're very dissatisfied. Geriatric internal medicine here. So, regular internal medicine, yeah, they're not happy. Let's back up and see where regular internal medicine is. So where's regular internal medicine? 7. Okay, so way down here. Very satisfied. So specialize and you'll have fun. Thanks for coming and asking me to talk about depression in the elderly. Depression in the elderly is great. You know, it's hard to get excited about something as sad as depression. However, if you look at all the syndromes, look at all the things that we treat with old people. Alzheimer's disease. Well, ma'am, I'm sorry, but we can't really help your husband. We can do little things that might help him. We can give him some medications, but you know, he's just going to go down the hill and he's not going to do well at all. Chronic pain. Osteoarthritis. Well, we can give you some medications that can help you, but you know, they can really hurt you. If we give you all these NSAIDs, you know, they're going to they might kill your kidneys, but you know, you won't have pain as you go to dialysis. But depression in the elderly is exciting because people get better. And they get better no matter how you treat them. You can use, we have lots of drugs, and we'll talk about those drugs in a little bit. But you have lots of, almost any drug, and they're going to get better. So if you can identify it, that's the key though. That's the big challenge, is identifying it. So here's what we're going to do. We're going to talk about the epidemiology. Lots and lots of people have depression. Presentation, atypical. Just like everything else in geriatrics, it does not fit the box. But as long as you know, don't look in the box, then you're all set. And the pathophys, I want to make this practical because this is a practical issue. Also, in geriatrics, where we set the bar, vary who's defining it. So what's depression? You know, well, there's lots and lots of criteria for depression, but which one use? Well, we're going to use this one or that one. So how you define it, I want to make this practical. Understand it carries increased morbidity and mortality. These people die from the manifestations of geriatrics, and if they don't die, they feel like they want to die, and there's lots of different methods of treatment. Overview, high prevalence, it's all over the place. Under-recognized, under-treated, we don't treat them for it. And it's different presentation and treatment. So, depression, especially among the elderly, is widespread. Lots of people have this. This is the most common psychiatric disorder in later life, period. Maybe not major depression, but depressive symptoms. It's not Alzheimer's disease, and it's not dementia, and it's not Parkinson's disease. This is depression, depressive symptoms, depending on how you identify it. It causes suffering, not only to patients, but their families and institutions as well. And you guys, because depressed people come to the doctors a whole lot more than non-depressed people. Increased morbidity, mortality, and this is a golden opportunity to improve health and quality of life. Come on, we got some room over here. Commonly seen in primary care practice. Many episodes go unrecognized, 70%. Many suicides seen by the doctor recently. Old people who commit suicide, we're going to talk a little more about suicide in a little bit, but patients who commit suicide, who kill themselves, 70% have seen a doctor within the previous month. 39% have seen a doctor within the previous week. So you have lots of opportunities and you can save your patient's life. So here's we have to talk about epidemiology to prove that this is common. 1% of community elders. And depressive symptoms, so this is major depression. This is the bad one. Depressive symptoms in 15% of community elders, and in primary care, depression or depressive symptoms, but treatable, something that could be treated and you could realize a benefit, is in 17 to 37% of folks. And in long-term care, the folks that I'm seeing right now over in the SNFs, lots of them. I actually, I give milk of magnesia and Mylanta and a sleeper and an antidepressant when I see them. So that's the RN. So 12% depression, 30% symptoms. Here's some risk factors. How do you find people who have depression? Well, they have risk factors. More of them are female. More of them are single, especially those who are widowed. They don't have a lot of supportive social network, and they have stressful events. There's a lot of, you can sit over here, Dr. Royal. Great, thanks for coming. Appreciate that. And they have a lack of supportive social network. So if you're alone, you have a chance to be depressed. If you're a woman, to be depressed. I can actually talk to you about some things that those of you who've taken care of Air Force people. Dr. Royal and I have been over at Air Force Village. And people over at Air Force Village have a less overall rate of depression because there's a social network right there. So you can't be alone at Air Force Village. You can still be depressed, but maybe not always depressed. So a substantial negative impact on the elderly. This makes these people feel horrible. Decreased functional ability. We need to define depression, and we'll do that in a minute. But again, the impact is significant. Decreased functional ability. They're too tired. They don't have the energy to do the things that they should do. They don't want to do that. Their function decreases. Their quality of life. They have increased disability and mortality. They use the medical services more often, and there's more of a caregiver burden. Here's some numbers on this healthcare cost. If we're looking for reduced healthcare costs, people who have depression or depressive symptoms typically spend $4,000 costs versus someone who is not around 2,000. So that's a significant increase. They also have a higher risk of developing coronary disease and a poorer long-term outcome with that. And again, it's a chronic illness. 30% remain chronically depressed. And recurrence is common. So if you have folks who are depressed, you have to keep watching them, because recurrent is common, and it interferes with the daily function and other chronic illnesses. I want to talk about suicide. Older people have the highest rate of suicide out of all groups. General population 12.4 per 100,000. The 80 to 84-year-olds, look at that, 12.6. This is twice the amount per 100,000. And they use the obvious means, the guns, the drugs, the hanging. However, with depression, there can also be an insidious degree of suicide. I'm all alone. I don't feel, I don't have the energy to go on. My wife has died. I'm all alone. I'm depressed. So I'm going to stop taking my medication. I'm going to stop eating. And when you see older people who have weight loss, think depression. Think that they may be depressed. If they stop their medications, they start drinking, they take risks, they get out and they drive. Think depression, think depressive symptoms. Just try to define this first. Depression in the elderly, types of depression. There's depression in geriatrics. If we talk about how you define, are we defining on the base of an older population or a younger population? And the answer is a younger population. It's kind of like how we find most things. Geriatrics, we sort of interpolate from younger studies. And with younger people, we have major depression, we have minor depression, we have dysthymia. However, there's a newly proposed classification, came out last year in the American Journal of Geriatric Psychiatry, that we say, well, among older people, maybe it's major depression, really bad depression,
or maybe it's subsyndromal depression. Maybe it's a little bit less. So, and I think this is probably something that's going to be more useful when we talk about depression in older people. It's not always the major depression. Depression in the elderly, this is depression in everybody. 5 or more of these on most days for 2 weeks, and a change, a departure from routine. And again, this is the STGEC, sleep disturbance, interest lost in formerly pleasurable experiences, anhedonia, guilt, decreased energy, concentration, appetite, psychomotor retardation, suicidal thinking, and depressed mood most of the day. We have to have anhedonia and the depressed mood most of the day. But if you're thinking about old people, how many times does an old person come to you and say, you know, doc, I have a hard time sleeping? Does that mean they're depressed? How about, I used to be able to do a lot of stuff, but now I just don't have the energy to do things anymore. I'm just not hungry, and I've been losing weight. Are they depressed? Well, are they depressed, or are they just a normal old person? Very, very important to think about that. If you have somebody that comes to you and says, you know, doc, I just feel guilty. I feel worthless. I feel that my life is just not worth living. That is classic depression, because there's a lot of other reasons for sleep disturbance, a lot of other reasons for decreased concentration, appetite, depressed mood. But when you come down to guilt, worthlessness, I'm just not worth anything, that in itself identifies depression. Look at these people, watch them closely. Let's talk about minor depression. You know, the other one was more than 5 or more. This is less than 5. This is like mini depression. However, think again in old people. This is the same thing. It's STGEC, but in 5, most days, over 2 weeks, but a change. Do we treat minor depression? That's a big question. I'm going to leave that open for a little bit. Dysthymia is another classic, not in old people, but just in people in general. Depressed mood most of the day for 2 years. So before you can identify dysthymia, you've got to say, well, you know, it's only been 1.5 years. You haven't really been grumpy. You haven't had all this criteria. Come back in 6 months. No symptom-free period for greater than 2 months. See, this makes no sense when you treat old, say, we're thinking about a diagnosis of dysthymia. Treat them. Make the diagnosis, or say, suspected depression. 2 or more during periods of depression, poor appetite or overeating, insomnia, low energy or fatigue, low self-esteem. Again, this, you know, the worthlessness, the difficult concentrating, feelings of hopelessness, dysthymia. But again, not really that classic in old people. How do old people present with depression? Maybe a distinct subtype, because there's some other things, as you know, that go on in the brain of old people that's not like the brains of young people. With young people, one of the key questions you would ask them is, what in your family been depressed? And very commonly they'll say, well, yeah, everybody's in our family is depressed. They're all on Prozac. Family reunions are horrible. But in old people, you don't see that. Less of a likelihood of family history. More cognitive and neuropsychiatric impairment. A lot of times in old people, depression occurs in conjunction with something else. Depressive symptoms can go along with vascular dementia. It can go along with Alzheimer's disease, Parkinson's disease. Very common. A substantial number of people who have Parkinson's disease have coexisting depression or depressive symptoms that would be amenable to treatment. A lot of times it's associated with cerebrovascular insults, ischemic small vessels disease. Insults that can occur in specific parts of the brain. If you have a patient who comes in with a stroke, hemisphere or the frontal lobe, think a little bit more that they're going to have depression. And you might want to, if you have a difficult time rehabbing them, getting them up and going, you may think that maybe they're having a reactive depression because of this. And a lot of times it's linked in people to medical illness and adverse events. How do they present? Here's how old people present with depression. Do they go to the psychiatrist? Do they say, gee, I really feel depressed today. I'm going to see if I can go to a psychiatrist to have us talk it out. And they don't. They come to you. They come to primary care docs. And they don't say, gee, I really feel depressed. Sometimes they do. That's a big red flag. But generally, they have physical complaints or somatic complaints just as they do every time they come to see you. A lot of times they have coexisting cognitive difficulties, having a hard time remembering stuff. So really, really important. But this is a primary care disease when we're taking care of it in the elderly. It's not a psychiatric disease. So you guys are the people who will identify it and treat and follow it. Very variable presentation in old people, exactly like everything else in geriatrics. They can be sad. They can be not sad. They can be irritable. They can be just grumpy. But maybe a change, though. They haven't been grumpy. They're grumpy. I had a gentleman who came to us in the geriatrics clinic at Wilford Hall, and he brought him on in. She says, he's different. He's grumpy. He used to be a nice guy, but all of a sudden he started getting grumpy. She'd go to work, she'd come home from work, he'd be sitting there all day, and just be at her. Just little things that's picky. So we did a good evaluation on him, and one of the things we did was put him on a little Celexa. And she came back a month later in follow-up and said, he's a different guy. You've given me my husband back. This is a very emotional family disease. And kept on Celexa. He was a nice guy, but so went off, he wasn't a nice guy. Irritability, social withdrawal. They may not want to be around. Decreased memory. We hear about pseudo-dementia. You know, the word, maybe they're depressed. When folks come on in for a dementia workup, the fantasy that we have is, gee, let's lab test and find out if this is reversible. Sometimes it is. Very rarely it's reversible. We do a B12 and folate, we do thyroids, we do chem panel, and we think about maybe depression. But think back, how many times is that B12 normal, and if you've given them B12, do they come back and say, hey, E equals MC squared? It's never happened. Thyroids, they might perk up a little bit, but they're still going to have their decreased memory. But in depression, sometimes it can help a little bit more. Tired. Doc, I'm really tired. I hurt all over. I can't sleep. I'm not eating. I'm losing weight. Real important. Big red flag, losing weight. Somatic complaints. They don't say, I feel depressed. I feel real down. The other reason why they don't do this is because as we're growing up was a sign of weakness, a sign of craziness, a sign of, gee, maybe you need to go to a nursing home. And I don't want to go to a nursing home, so I really won't say. But I do have pain, and I can't sleep, and I have a headache, and I have diarrhea or constipation. I mean, they'll look at things, they'll just obsess on little tiny things, and they'll make you feel miserable because you can't do anything about it until you identify. I have heart palpitations or I'm dizzy. What's the differential diagnosis of dizzy in old people? And expanding. So that's this. If you don't think about anything else in this entire talk, think about this slide here. When old people are depressed, they come in with somatic complaints. They don't say this, they say this. Here's another problem. Ageism, the diagnostic dilemma. And we're even guilty of ageism. I'd be that depressed if I was that sick. You got 100 things that are wrong with you, and you've got 200 medicines. Yeah, your life is based around your sickness. And I can sure understand why you'd be depressed. We think of it as a normal part of aging, or somebody does. And these vague symptoms, masked diagnoses. Why are you having a hard time sleeping? Competing problems. So if someone comes in, you have 15 minutes with them, and you can talk about their blood pressure and their cholesterol and all these obvious things. How's your blood sugars? Here's my number, doc. Okay, let's take care of that. How's your cholesterol? Here's my numbers. You know, let's do all these numbers things and treat these things. How are you feeling? Well, I feel can't sleep. All right, let's talk about that. Could you be depressed? That's going to take tons of time to talk about it, so you can take care of about 5 or 6 of the other competing problems in that same amount of time. This is something that's sort of time intensive, and commonly after they come back to see you for the umpteenth time, you sort of say, well, it can't be all these other things because we looked at them, might be depression. And that's a lot of times the way it is. If they're demented, they can't tell you a lot of the stuff, how they feel. And also this denial. I don't know, now taking care of people who have depression, I'm a little bit less to say there's a stigma of mental illness. And I think medical people now seeing that depression in our research is more of a medical illness. We don't have the stigma as much. They still do. And they don't want to have a label of mental illness. We're getting old, Jake. So are these guys depressed? I don't know. Areas of risk factors for geri depression, and again, psychosocial. So commonly, when bad things happen to old people, they respond by getting depressed, or acting depressed, or developing depressive type symptoms. Retirement, bereavement, loss of autonomy or independence. I'm on a fixed income now. That's a hard thing to do. Social isolation and loneliness. You know, my spouse has died. They're my social network. She had all the friends. Now I'm all alone and nobody's calling. You know, so there's a big part of depression in bad things that can happen. Also in medication, sometimes we cause depression or don't help it by some of the things that we do. We don't really use propranolol an awful lot, although we can sometimes in people who have dizziness, we might use it. We do use atenolol and metoprolol. Beta blockers sometimes can cause that. Steroids, bad things in old people, can cause depression or euphoria. We don't really use cimetidine that much more, but you know, Zantac can cause it, and benzos, we use lots of that, and those are risk factors for geriatric depression. Medical illnesses are big risk factors, and maybe not of it decreases your functional ability, but maybe there's something else there that we just don't know about. Research will bear this out. Cardiovascular, a substantial number, about 20% of the people, one of these articles, I have a really good bibliography in the back for you, and one of the articles said that 20% of the people who go for cardiac catheterization have treatable depressive symptoms. Really wild. If you have an MI, you have about a 50% chance of having depression in the next 6 months, or depressive symptoms, something that's treatable. Congestive, stroke, again, depending on where it is. If it's left side, if it's frontal, you may be depressed. Alzheimer's disease, very good. That Alzheimer's disease, up to 20 to 25%, again, depending on how you define depression, can have depression or depressive symptoms. Cancer, almost like a paraneoplastic type of syndrome, pancreatic, breast, colorectal especially, but other conditions too. So if you go to your psychiatrist and you say, gee doc, I'm depressed, do you think he's going to make the leap between maybe you're depressed because you're constipated, so here's something for your constipation, we won't treat you for your depression right now, but constipation, deafness, renal disease, chronic pain, all these can cause depression in old people. You know, and it sort of suggests maybe there's something other than just a chemical imbalance in the brain people that's causing old people's depression. Is this a different syndrome? Who knows? How can you diagnose it? Again, listening to what they say and having a high index of suspicion. Very important. And that's why I just want to make this really practical, get you thinking about this, not so much into the pathophys. Listen to what they say or imply. Think about their functional ability. if they're having an acute decrease in functional ability, are depressed? Is there something going on with that? You know, certainly H&P and labs, or you know, if their family drags them on in and they say something's going on, he's different or she's different. Think about that. Lots of different ways you can diagnose it officially. The Beck Depression Inventory, 21 items, the HAM-D, 21 items, Geriatric Depression Scale, and there's several other of them out there. And some of these can be administered by, if you have a nurse or if you have an office staff, or if you just give it to the patient and say, you know, come on back in a week and let's talk about this, although that may not be the way to go. Here's the established Geriatric Depression Scale. And there's 15 items. And satisfied with your life? Yes or no? Do you get bored? Yes. You think it's wonderful to be alive now? No. So if you have greater than 5 wrong ones, that suggests depression. Over 10, almost always depression. So the challenge is not only in diagnosing it, but also in treating it, because patients may not comply with the treatment. You very commonly see, if you have an opportunity to buy food or medicine or rent or cigarettes, what you're going to buy? You're going to probably in that reverse order here, probably not the medicines, that can kind of go to the end, but patients may or may not comply because it's stiff. And they are. These medications are expensive. They may not start working right away. You may need to give the patient medication for a week, 2 weeks, 3 months. You can't really say it's not working until it's been about 12. Although, if you really care about your patients, you may go with the artificial time. A lot of them have side effects, and they can have some bad side effects too. But they can have some good bad side effects. We'll talk about that in a minute. And drug-drug interaction is very common. So when you treat, just when it's major depression, maybe if it's minor depression or dysthymia or that subsyndromal depression, maybe they'll snap out of it. They might. I mean, if it's bereavement, very commonly, bereavement can present with all the phases of depression. And maybe in a few weeks they might feel better. You might not want to treat them right away, or you might treat them right away if they're not eating. Treating major depression is effective, and it doesn't matter who treats them or where you treat them, just treat them. Primary care, mental health specialists, young and old, all of them, a substantial number of folks do better. There was one of the articles that I saw compared Celexa and Effexor to see which one does better. And placebo found that just the two that are treating, just Celexa and Effexor basically treated the same. 20% got real good, 60% got better, 20% got worse. So if you have 60 to 80% of people who improve with treatment, that's pretty good. So treating is real important. It's just finding out about that. Lots of ways you can treat them too. You can treat them with drugs. You can treat them with ECG. The over 65 group is probably the one group that does with ECT, although there's some bad things that can happen with that. Psychosocial therapy is real important, and if you ignore this, if you just give them a pill and ignore the other things that are going on, you're ignoring it's a missed opportunity. So right now the standard of care is biological therapy, pharmacotherapy, and when you can or when it looks like it will benefit them, psychosocial them to a counselor or have somebody talk to. You have to have a psychiatrist or psychologist, a social worker, somebody. Very treatable, again, 60% improve, depending on how you classify it. Most antidepressants equally effective, lots of side effects. Let's talk about those side effects. SSRIs. When Prozac came out, the sun on depression, because previous to that, we had only bad things. MAO inhibitors, TCAs are okay. They work in some patients, but they're very dangerous. If you take an overdose of TCA, it's going to be bad, and you're going to really punish your house staff, those who have to sit in the ICU with you all night. We take an overdose of SSRIs, a lot less. They block the reuptake of serotonin. They're once a day dosing for the most part. They're tolerated, they're effective. If you only have to remember to take your medication once a day, that's a real boon when you're talking about old people. Talk about Cytochrome P450 if you have any other medications that also are metabolized with Cytochrome P450. Think about Celexa, think about venlafaxine, Effexor. These two are a little bit better. Talk about some other effects. Wellbutrin Bupropion. If you need to minimize sexual side effects, there are probably all antidepressants will have some degree of sexual side effects, bad sexual side effects on folks. Wellbutrin might be a little, if you need to minimize daytime sedation, think about this. If you need to minimize weight gain, think about this. However, if you need to, if you have someone who is a frail old person who you might be thinking about, I want to give you one drug. I can give you Megase, or I can give you Remeron. It may gain a little bit weight from it. You may be sedated. Let's take it at bedtime. And if you have someone with a hard time swallowing, you can use the Solutabs. Put it on your tongue and it's gone. Don't even have to. I'll just run through some of these other ones quickly, but you know, the main thing is these young doses, the starting dose, were based on a young population, less than 60. With old, think about start low, go slow. Zoloft, common. Zoloft has been studied a lot in elderly depression, and it works pretty well. Short half-life, steady state concentration in 7 days, so it takes a little bit of time to get where it's going to go. But you want to start low, 12.5 to 25. Don't go up to 200 or you'll have real problems. Paxil. Paxil is the most anticholinergic of SSRIs, but it may work. It may help them. It may cause dry mouth constipation. So if you have somebody who has diarrhea, maybe you might want to think about Paxil on them. If you have a real frail person, you may not want to think Paxil. You may want to think something else, but if they're sort of robust, that may be something to think about. Effexor, you know, blocks not just SSRIs, not just the reuptake of serotonin, but norepinephrine, serotonin, and dopamine. And this is RI, but it can help. And in old people, Effexor works pretty well. You can get nervous, nausea, sweating, dry mouth, retention, but again, it's one to think about. And start low. Lexapro is my favorite. I started using it, the drug rep, as we all get our information from the drug reps. Drug rep came through and said, it's great in old people, like they all do, and said, it works real good, it works better than the others, try it. And he gave me this nice Lexapro pen. So next time I was writing out a prescription, I had this pen, I thought, what'll I do? And I saw the pen and it said Lexapro, so I said, let's try Lexapro. That's right. So, but Lexapro, in my experience, and I don't know if anybody else has shared this, seems to work a little quicker. And it works pretty well. And I haven't had too many people who have said that they have a lot of, I have, always have.
So that's just one of the isomers of citalopram, is that what it is?
Correct. This is the
I don't think we have it on formula.
No.
S, an enantiomer, and it's 100 times more potent than the R. So you can give low doses of that, but in my experience, it's really helped. That's what I like. And I've had people within a week say they feel better, and it's something that's observed. Sometimes you got somebody who's just, they're in bed, they're not going to get out of bed, they are so almost catatonic, you can't nudge them with a stick of dynamite. Think about Ritalin. Maybe a little bit in them, give it at bedtime, but this may perk them up while you're waiting for that SSRI to kick in. Maybe as soon as a couple days. You might get them up out of bed and eating. This is not something I would recommend keeping on for a long time, and I would not recommend going up to 40 milligrams. a day on that. But it's something you can keep in your back pocket. And again, the other things, counseling, psychotherapy, exercise, getting around. I trained up in Vermont and in Tacoma, and I know everybody has seasonal affective disorder in January and February, and their bright light therapy a lot of times can surprisingly help. But again, ECT is something that can really help. How long do you treat? Think of this as a chronic problem. This can be recurring, and after they have had a complete remission or doing better, think about 6 months after that, or think about keeping them right on if they're doing well. If there was something that happened, maybe a bereavement that you said you need a little bit of boost for a while, after 6 months, think about getting them off. Don't stop them, taper them down if you can, and just keep an eye out for recurrence. And if they have several recurrences, this is a great article, and it said unfavorable chronic or relapsing course in approximately half the cases. I don't know if I would say half the cases, but a substantial number of them. And again, if it worked before, try it again, same drug, same strength, and continue on a little bit longer, and continue other treatment modalities. And if you ever have a question or concern about depression, or you want to just ask me a question, please send me an email or give me a call, because I always have my phone on. And before we take questions, I want to tell you one more thing about geriatrics. There was a time in history where we had the golden age of geriatrics, and unfortunately, it's gone. We've missed it. So I become real excited when I get a 98-year-old, because I think, all right, this is a geriatric patient. But think about this. The days of Adam after he became the father of Seth were 800 years. And he had other sons and daughters. Thus all the days that Adam lived were 930, and then he died. So when you look at Adam's geriatric.
Although shortly after that in Genesis, God decides he's not going to do that anymore.
That's right, that's right.
It's like decided that living that old was a bad idea. Henceforth, no one will live more than 100 years.
That's right. That's it. Methuselah, the oldest person ever, 187 years. He became the father of Lamech. So he had a son at 187. And then he lived 969 years, and then he died. And Noah, all the days of Noah were 950 years, and after the flood he lived another 350 years, though. This is a guy who has 9 lives. And you know, old people can do a lot of stuff too. Abraham fell on his face and laughed and said to himself, can a child be born to a man who is 100 years old? Can Sarah, who is 90 years old, bear a child? Oh, that Ishmael may live in your sight. No, but your wife Sarah shall bear you a son, and you shall call him Isaac. So at 90 years old, that's pretty good. But what was true back then is also true now. Do not cast me off in the time of my old age. Do not forsake me when my strength is spent. And that's why we're here. That's geriatrics, and it's wonderful. And it's been a tremendous career for me, and I've enjoyed it, and I know you will too. And I thank you for your time. And if you have any questions, I think we might still have a little bit of time. Great. Well, thank you very much. It's my pleasure to talk to you.
Surely.
Geriatric stories, geriatric patients.
Because we usually, and it must not have been any issues to take with you. Thank you very much.
Great. Thanks for asking.